Well, good morning. This is the ECHO Clinic, the Pain Management Clinic. I'm Dr. Michael Lindowski. I am accompanied by Mr. Paul Snyder, who is an alcohol and drug abuse counselor. Dr. Dennis Patterson, who is our physician on the panel, should be here shortly. We're going to go ahead and begin. And welcome to all of you. Today's topic, we're going to talk about motivational interviewing, motivational questioning for people with chronic pain. And I am a pain management psychologist. I've worked in the field for the last 30 some odd years, and would love to share with you a few things that I've learned about this topic and working with folks that have chronic pain.
Just a second, Mike. Yeah. Dr. Chrysler, it appears that you're sharing your screen. We can all see your screen right now. There should be a little red thing at the top of your screen that says stop share.
So we have I guess a technical issue here. Somebody is, as Troy was saying, needs to click a button somewhere.
I can't find it.
Can't find it.
I don't know. Control either.
Okay, we're still trying to figure that out. Should we wait? Mr. Troy, you're the controller here.
Yeah.
Well, it looks like you found something, maybe.
Yeah. I don't see his Zoom anywhere, though. Dr. Chrysler, can you hear us?
Yeah, I can hear you, and I can't find what you're saying. I don't know what to do. I'm not a computer guy. If you don't mind, I'll just leave it the way it is. I don't care. I just want to listen.
Okay. Okay. I think that should work to stop it.
It did.
Maybe we.
Okay, did that work? Does everybody not see his screen anymore? Okay. Thank you.
Okay, hopefully we're back on.
Yeah, we are.
Wonderful. In the spirit of the ECHO project here, it's intended to be very interactive, and so with that, I understand we may have a case that would like to be presented to this pain panel. So we'll make sure that we have time to get through, because last time we did this, the cases took up a big chunk of it, and we weren't able to get to this, but we'll try to deal with the case, address it, and then move on to the topic for today. So thank you for that. And so,
yeah, Dr. Walters, are you there? Can you hear us? And I'm not sure if we have audio for you.
Can you hear me?
Yeah, absolutely.
Yeah.
Perfect.
I'm here.
would you be able to perhaps present the question and the case?
No, I don't have one today.
Okay.
Oh, okay. All right. Well, in that case, then let's forge ahead with motivational questioning. So, let me see here. Do we have the?
Unless there are any other cases out there?
Anybody else like to? Okay. Okay.
Okay. Go ahead with your time.
PowerPoint. Okay, great. So as I mentioned, I'm a pain management psychologist, and my hope today is to share with you some of the things I've learned about working with people with chronic pain, and perhaps a way of asking questions, a way of soliciting more information than simple yes/no kinds of responses, with the ultimate goal of being able to try to get at the heart of what's going on with the patient. So the topic is motivational questioning, and what I'd like to start with is some fundamental assumptions. In this context, the presentation is intended to deal with people that have chronic pain, in contrast to acute pain. And a major important difference, because in a one dimension we look at a distinction between acute and chronic pain, perhaps if nothing else being just a matter of time. When I first started in the field back in the 80s, we used 6 months as the cutoff for chronic pain, beyond which chronic pain would be classified as the such. We've since moved that to about 3 months, and I think it could be argued it could even perhaps be shorter than that. But again, the fundamental assumption here is that this particular presentation is intended for people that have chronic pain problems, not an acute issue. So that's number one. The other one is that by definition, chronic pain is a biopsychosocial experience. it moves beyond the physical and the biological. And with that in mind, we need to take a look at the emotional factors, the social factors, the psychological factors that begin to play a major role in the perpetuation and maintenance of someone's pain problem. So that's the other issue. So the problem, I think, is that people get stuck when they experience chronic pain. And I really think that what happens is they need to be heard, and they need to be able to tell their story. And the problem, unfortunately, is that today most physicians have, I think, about 8.5 minutes per patient to be able to spend time with them. So there really isn't, it's set up for some frustration on both parts. But I do think that through strategic types of questioning, the physician and the healthcare provider can really get at the heart of the matter if they're aware of just a few things that may help them in the course of that face-to-face interaction with that chronic pain patient. And so for today, my hope is to share some of those with you, and ideally you'll leave today with something that you didn't have before we started. So let's see here. Okay, so one of the things I want you to consider in terms of persistent pain is obviously, the question, is it a problem for the patient? And I would invite you kind of globally to think about what is your understanding of how they're dealing with it, how they're feeling about living with persistent pain. I would also invite you to kind of consider what do you think they think should be done. Oftentimes I'll tell people that in many ways they're the expert for their pain, and therefore we need to listen to what they have to say and what they think. I would also offer you the observation that you perhaps know what their diagnosis is, but oftentimes I've had patients over the years tell me they don't know what their diagnosis is. They perhaps haven't been told, or they haven't seen it in a chart, and even if they have, oftentimes they don't understand it, and it's possible that they don't believe that their impression of what their pain problem, their pain generator is, may be very different than yours. And so I would invite you to kind of solicit some information from them in terms of whether there's a good match there or not. The other issue, of course, is do they see themselves as playing any role in this strategy for dealing with their pain? Oftentimes, and we'll talk about this in a little bit, especially when you transition from the acute to the chronic phase, patients are trained to believe that it's not their problem, that it's yours. So I would invite you to take a look at what role they're kind of emerging and seeing themselves as playing in this. And then I want to introduce two kind of concepts, a medically focused mindset and what I would call a rehabilitation focused mindset, and what the distinction and difference is in those. So just a little background in history. We'll go through this very quickly because I'd like to have more time for discussion. Historically, we have the stages of change work that was done by Prochaska many years ago in the mid-'80s when I first started. And the concept there is that we go through these series of stages to finally get to a stage where you're incorporating more self-management issues. The other more recent, and or actually at the same time, Robert Kearns, who did a lot of great work at the VA hospital many years ago, created the concept of readiness to adapt a self-management approach to chronic pain. I think the two of these kind of merge together to really set the stage for having us as pain management helpers to look at this concept. And I'll just, a couple quick screens here. Here's Prochaska's stages of change model. I'm not going to necessarily go through any of these specifically, but I just wanted to show you on a slide how they kind of lay out and what some of their names are. Pretty familiar to most of us, I think, anyways. And then I have this next slide is the pain stages of change questionnaire that Kearns developed. And I just took a copy of it here. You can actually get this. I think we have it here at Echo, and you can download this if you'd like to look at it. You can just see the first couple questions there, what it's trying to assess. I've been thinking about the way I cope with my pain could improve. And he taps into these 4 or 5 different stages of change so that very quickly you can get a snapshot of where your patient is at this particular point in time. So it's a very useful tool to understand where the individual has to be at that point in time. So the question then is, where is your patient focused? The idea here is that the difference between this medical and rehab model, and I'll show you a slide where I kind of lay it out as kind of a continuum, but a medically focused individual are the classic acute pain patients that are just into the chronic stage, that they're looking for a fix and a cure. They're externalizing things. They want you to do it to them. And you'll see statements, or you'll hear phrases like I've got listed here. I'll read just a couple to you. But, you know, they want to be fixed and cured and have their pain eliminated. They say, you know, man, if I could just get rid of this pain, my life would be better. How many times have we heard those kinds of statements? Or if you look at the last one there must be a reason for my pain. You know, all I know is that I have to keep looking and find that right doctor who will be able to finally figure this thing out and fix me. When you hear these kind of comments, that's some insight that they're more likely in the medical side of this, if you will, this continuum. And they're going to be very externally focused and want you to do something for them, which can, in the end, be quite frustrating in the long run. Okay, in contrast to that, in a sense, I think what I've looked at trying to do is help people kind of shift and slide a little to the rehab focus. Now, the interest here, the focus here is that the patient isn't any less interested in trying to reduce pain. I think the big key, though, is that they're willing to look and explore new ways of coping with pain. They're open to say, all right, this is my problem, and I want to start taking some responsibility. And that's kind of the direction that we would like to get our folks with chronic pain to move in that direction. And I've kind of summarized some of that to, of course, we have expecting to be fixed and cured is on one end. Taking action is on the other, and some of these concepts, you know, I'm not really ready to think about making any changes. Then you kind of get into the yeah, buts, you know, I could do this, but to finally believing the change is possible and then making some actual behavioral changes. So my thought was, I put this together the other day that, you know, imagine a continuum. So on the far right, we have the medical mindset with the entire focus is on you doing something for them, expecting to cure, expecting to be fixed, to the rehab mindset, which is, hey, I'm ready to make some changes for myself. So I would invite you to consider this concept in your head. And where is your patient at this moment in time when you're with them? And you may even want to use some of these phrases or these labels to say, where do you think you fit in this? And I think that may be of some use to you. What I've had to change, I'll tell you in my career, is that early on, I actually, admittedly, probably externalized this and blamed the patient that I would see that they're not at a rehab mindset when I'm working with them, expecting fully that they should be there, when in fact, you know, I think that was an error. So it's not good or bad where these people are, or where your patient is, but it is something you want to pay attention to and look at what implications that has for their involvement in their willingness to engage into a self-management approach. Okay. So examples of some of the other phases. Folks that are not even ready to think about change, the classic phrases there are things like, people are telling me that I have to learn to live with this pain, but I really don't want to have to. I hear patients tell me that all the time, that the doctor just says, hey, you're going to have to learn to live with this. And you sense the resistance to that they feel like they should somehow not have to do this. I also get, in the second kind of example there, issues that it's not fair, it's not right, I don't deserve this. A very strong feeling is entitlement and anger. In fact, in my experience, anger oftentimes is even more prevalent than depression in many of my patients. So this particular phase, you're seeing that kind of a reaction to having to live and deal with chronic pain. You can notice people then moving to the next category, if you will, or the next stage, where they're using the word but. It's a yeah, but kind of a thing. Yeah, but I don't really want to do that or whatnot. And a number of years ago, I heard a nice explanation of the word but as an eraser. When people use the word but, it's like an eraser in their statement. So the three statements I have up here, if you read the first part of well, I'll take number 2. I tried new pain medication a couple months ago, but the side effects were really bad. So essentially, you could take an eraser and erase the first half of that sentence and just say, hey, the side effects were really bad, and I'm not going to do it. So when you hear your patient say a lot of buts, okay, think of whatever they just said is really not that important. It's what's coming after the but that you really want to listen to. But this becomes a real, people get stuck here very, very hard. And this is where a lot of my folks kind of, this is a hard obstacle to get over, the yeah buts. My suggestion to them is to consider substituting the word but with the word and. So you take the same sentence, I tried new pain medication a couple of months ago, and the side effects were really bad. Now there's a subtle difference in but versus and, because and becomes additive. I'm willing to possibly still do whatever the second part of that sentence is, if you will. So there's a whole section that we could talk about, just the strategy of language in pain. I would encourage you, though, to listen for the word but, and then if you can, recommend trying to reinforce the word and in that very sentence. Have them do it in the session and ask them to see how that feels. You know, my classic phrase is, I would have gone to the movies with my family, but my pain was too bad. And that's very different than having the experiences that I went to the movies with my family and I had pain. You at least went to the movies. And that's a big part of what I think pain management is getting people out there moving again. So believing change, open to change, but. And then we move to, believing change is possible. Sometimes listen for the language, listen to what they say. If you're hearing words like, I'm ready to learn new ways of coping with pain, that may be an indication they're willing to be open to try things. This pain's been with me for a long time. Yeah, I'm willing to take a look at some new strategies. These are change statements, and you want to listen for them, because if you hear them, you want to reinforce that. So it's the language of change. And then finally, I'm ready to make changes. Probably one of my favorite questions in 34 years of doing this work is the second question there, which is, I can get on with the business of living despite my pain. We'll talk a little bit about ruler questions, and that's a very good ruler question, because most of the people that I meet when we get started, they'll respond to that question 0 to 10 with a 0 or a 1. I'm not ready. I can't get on with the business of living despite my pain. And what I would do is I try to invite them to look at what would make that a higher number, where you could get on with the business of living, and what would that suggest for you to do. So again, it's the idea here is your questioning can help invite the idea of taking some responsibility and managing some of their response to pain on their own, rather than it being an external issue that you need to fix them. Readiness to change, these are some, I think, key issues. It can be developed. We can reinforce it, we can teach it, and it can be enhanced in people. It's not an either-or thing. And I get back to earlier in my career, I probably didn't believe that. I thought wherever they were is where they were going to be stuck. But that is not true. People can change. So it is malleable. And how ready you are now doesn't indicate how ready you'll be tomorrow or the next day. So that's what I needed to learn, that even though somebody may be stuck in the I want to be fixed and cured, that doesn't mean that they can't make some changes in a day or a week or a month from now. And I think the last point here, motivation is influenced by many things, including skills and ideas about pain. And I'm going to talk a little bit about some of the ideas that I've seen patients develop that can be really problematic and not true. So we do need to take a look at what people are thinking about with their pain. So why don't people change? Well, you would think that if somebody's hurting, that they've got pain, that they'd be easily persuadable to do anything. Change a diet, exercise more. You'd think that they'd be willing to do this, or take their medication without going over, or having problems. You think they'd be motivated because it's painful. And yet, what people learn, unfortunately in some cases, is that laying down, resting, inactivity, avoidance, continue to externalize. The doctor needs to fix me. I'm just waiting to be fixed. Catastrophizing about their pain. All of these things, poor sleep, getting out of shape, going to bed late, sleeping in, creates potential fatigue. It's incredible the number of vicious cycles that can kind of occur when someone is living with a chronic pain problem. And they do this despite the incredible evidence of how poor a strategy it is. But so it's not inherent to think to do the right thing. And so it becomes a challenge. So what I'd like to do right now is take a break from this kind of didactic thing here. And I want to, if I could, invite you to think about the last pain patient you saw. And if using that idea of this continuum of medical focus to rehab focus, if anybody would be willing, where were they on that range and how did you deal with it? Anybody like to share a case or a... The last patient you saw. Certainly you have had a last patient you saw. Guesstimate, where do you think they were on that scale of self-management versus external? If somebody would be willing to share, that would be great.
Just remember to take yourself off mute. There's the microphone icon in the lower left corner of your screen.
Does that concept have any value or utility for you, do you think, to conceptualize your patient in that regard? Okay, well, well, guess what? I have a plan B. Here we go. Plan B is to then say, well, I invite you to think about that. I invite you to think about that as a possibility. May I go back to the slides? Okay. Oh, yeah, do we have somebody?
KHCPA, do you have a comment?
I don't. I had a patient yesterday who was being proactive. She's a long-time chronic pain person, and we had to take her off pain meds for renal function. And she's moving forward with epidurals and wanting to be active, but is having a difficult time. And sorry, I used that but word.
Oh, and she's having a difficult time, right? Yeah.
I'm sorry.
I mean, I was just saying, and she was having a difficult time.
That's it. That's it.
Rather than but she was having a difficult. Yeah.
Can I ask what medication she was on, or is on, or is trying to titrate down?
We had to take her off of diclofenac, and she had been put on Suboxone to get her off the narcotics, and it put her into renal failure. And so we had to take her off of that. And she's, she tries to be active. She's never been active in her life. And so she's set up this next week to get an epidural. And hopefully that will give her some sort of measure of relief.
And I'm sorry, could you introduce yourself and tell us what location you're at?
Oh, sorry. I'm Ann Miles. I'm a PA out here in Kingston, Nevada at the Kingston Health Center.
Okay.
Thank you.
Yeah. One of the things that I find most helpful is when someone is titrating down, especially for the opioid agonist, is if explain the discomfort that they're going to feel and the exit strategy and the goal. And so when you're partnering with the actual patient, they can calculate, okay, this is where the insomnia came in. This is why I have that constipation, and now this is why I'm leaking. This is why I'm having piloerection to feeling nervous, anxious, and having anxiety. And then also the things that, if they've been on it for quite some time, the emotional response that they predictably will be feeling, which grief, remorse, frustration, anger, all of the natural elements that are going to start coming up. And of course, you have 8 minutes to work with them through all of this. That's why it's good to have a team approach, so that one of the ways that I work with my psychiatrist or my other medical physicians is they would send them to Dr. Lewandowski or myself to explain all of this, and then to help them go through those stages of change. Because when we recognize the stage of change, the idea is it's not a label, it's just to take a snapshot of where they are that day with all of the different things that are going on, and then help them progress through a healthy, kind of systematic way towards a goal that we can both reach.
Good. Well, I have a quote up here from Charles Darwin, one that I really enjoyed. It's basically, as he says, not the strongest that survive, it's the ones that are most responsive to change. And I would invite you to consider the people you're working with persistent change. It's really a survival challenge. And my invitation to them when I'm working with them is saying, you know, how adaptable and flexible can I work with you and help you become? Because you know, strength is not going to help you necessarily get through this. Potentially also not how bright you are. It's how responsive to what's being thrown at you that's going to really make the difference. So it's in that spirit that I like to form this kind of collegial team approach rather than I'm the expert and they're the passive subject to just listen and take notes. So persistent pain changes our ability to be adaptable, flexible, and changed. The other quote that I enjoyed was that motivation is a fire from within. If someone else tries to light it underneath you, it's not going to burn very long. So this is not to say that education is not important. It certainly is. And if we can facilitate and get them engaged in this process of thinking of self-management, we may do just that much better, is the intention of this, I think. So, you know, what you say is important, and people come in with a certain motivation to change. So I want to really emphasize the valuable role that you play as a pain management healthcare provider, and what you say can certainly influence where they end up. So looking at some ideas here, the whole concept behind motivational interviewing, in my opinion, was best captured. I'll show you a copy of a book here that I strongly encourage you all to get. It's called Motivational Interviewing in Healthcare. Now, this is written by Stephen Rolnick, a fabulous book. It offers many of the suggestions. Troy's going to put it up there on the screen. Many of the suggestions you're going to hear in the next few minutes. So it's a fabulous resource, and I found it very helpful. Many of my colleagues that I've shared it with have found it extremely useful. So the idea is that even a session or two with your pain patient can really make a difference and start setting the stage for having them think in a different way about their pain problem. So brief interventions can make a difference. So when you've got your 8.5 minutes, what I would encourage you to do is to not ask questions that lead to a one-word response. So it does take a little practice to get out of that. But once you realize that you can ask some questions in a different fashion, it's amazing what that pulls from the individual. So the goal again is to just stay away from getting up with yes, no type of answers. So questions like, you know, what would you be doing differently if you had less pain? That facilitates an open-ended kind of response, and the individual now will start sharing with you some of the things that may be important to them, things that they value. So some ideas here. I come to my favorite motivational motivational questioning tool, which is called the ruler question. So essentially, if I could set the backdrop to this, imagine that you have this ruler where you gauge the person's response. So there's two parts to it, or there can be. The first part is a question that talks about how important something is to them. And then the second part is how confident they are in engaging in that activity. So if we used, let's say, walking around your neighborhood as a form of exercise and movement. One of the things I learned many, many years ago is that movement is life. And for people with chronic pain, pain typically teaches them to sit still and do nothing. So they have to inherently try to do something outside of that. Movement is always valuable. So if you phrase the question and you ask the person you're with, how important is it for you to say, to be able to walk around the block as a way to get some exercise? And then say on a 0 to 10 scale, if 0 is not at all important, 10 is extremely important, what number would you say? And you wait for a response. No matter what number they tell you, you have two follow-ups. The first follow-up is, assuming it's more than 0, you say, what made it a 4 instead of a 0? Again, it's not a yes or no answer, and they have the opportunity to tell you why. And now they're telling you why it's important to them to be able to walk. You're not telling them why it's important to walk. They're telling you why it's important to walk, which is exactly what you want them to be doing, because now they're taking some ownership of that. Follow that up with then, well, you know, what would it take for you to, say, walk around the block? How confident, or, you know, what would it take for you to go from that number to a higher number, from a 4 to a 7? And you start getting them to take, you're now beginning to hear some of the reasons that they may have trouble doing that. Again, grist for the mill, certainly content for discussion. So that's taking a look at how important something is, and then you follow that up with how confident are you that you're able to do that with the same type of strategy. So I want to take this and show you how I use it in my practice. So I utilize a screening questionnaire with all of my pain patients where I ask them 0 to 100%, 0 to 10 agreement. Here's an example of one of the, I call it my skyline profile of their ideas about living with pain. This is kind of my psychosocial MRI, I call it. And with that, basically what you see here, the individual, the person I'm working with is represented by the black bar, the gray bar, the shaded bar is a sample of over 2,000 people I've had and completed this. So if I could direct your attention to kind of the right-hand side there, if you can read it, you probably can't, but thank you. The question is drop in activity levels. So this person's drop in activity levels is pretty significant. In fact, I think they picked here about a 9 out of 10. The question right next to it is fears of re-injury, which was very close to my sample response of the 6. So if I combine those two, I'm saying to the person, let's see here now, your activity levels have dropped pretty substantially, and you kind of have a little fear of re-injury. You know, I'm curious what makes those numbers a 6 and a 9, and why not a 3 and a 4? And you now get them to respond to the idea of fears of re-injury and drop in activity levels. And in the case that I'm presenting here, the patients, when I asked them that, the patients said, well, I still have pain. And if you look at the far right, you'll see their worst, average, and least pain are 10s across the board. So this person has a lot of pain. And I said, okay, so you have a lot of pain, and that's the reason you're not doing something. And he said, yeah, if I have pain, Dr. Lewandowski, that means I haven't healed. And if I haven't healed, I can't, why would I do anything that could make my situation even worse? So with those questions, I was able to get at a core belief that this person had that I wouldn't have had an idea of, that they're associating pain with lack of healing, which, and I'll be the first to say I'm not a medical doctor, but may not be 100% true. The healing process takes place irregardless of what the person thinks, does, or feels, and possibly even what their pain level is. So it was an opportunity for me to be able to talk to them and invite them to talk to their doctor about how healing may not be a huge role in holding them back, because this person, in fact, has had pain for 2 years. So the idea here is that you take any scale there and you ask the ruler question, which is you take a third of it, half of it, pick any number, and ask what that is. I'll give you another example. If you look here under need for more testing, the third from the left, it's also a 10. So I said, so Mrs. Smith, you really feel strongly that you need some more diagnostic testing. And she said, well, it's not that I really need another x-ray or an MRI. I've had, 3 months ago I had them. She said, what it really is that I'm scared. I don't know what's really wrong with me. I want to find out what's wrong, and maybe testing would tell me that. So I said, why is it a 10 and not a 4? And that's what she said. And I said, okay, so you really need to have a conversation with your physician about what your pain generator is. And I go back to the idea that does it match what you as the physician think? You may be really surprised. As a psychologist, I feel like I'm blessed because I get to spend 55 minutes with someone versus your 8. And I have the luxury of being able to sit down and kind of listen to this. My hope is that through motivational interviewing, the idea of how you can ask some of these questions with some data here, you can get at the heart of some of the issues that may be actually inhibiting them from growing and moving on with their life despite having pain. So the ruler question is very, very useful. Any thoughts or comments on this?
I have a question. Do you compare these different issues with all of your people? And if you do, what are the biggest emotional issues that you see? I see depression, anxiety. There's a whole bunch of things, but if you had to make a blanket statement of which are the most prevalent or the biggest areas, which ones would you focus on?
Well, as a pain psychologist, I look for I look at the depression, anxiety, anger, frustration, perhaps even the belief, the expectation for cure, the idea that I can be fixed and cured. I tend to focus on some of the cognitive issues because of my background in training, but I found actually the sleep problems question, although it's not elevated on this individual, sleep is probably 80% of the people that I see. They have disturbed sleep, they have daytime fatigue, daytime sleepiness, and they don't get rest. And you can just imagine, if you have an engine that needs to run and you're not putting any fuel in it at night to recharge it or cleanse the engine, if you will, you're going to have a hard time coping with pain. So in my experience, sleep problems is a huge issue for people with pain, and many folks have obstructive sleep apnea. Along with central apnea if they're administered a lot of opiate medications, which is often the case. Point is, I'd like to just introduce the idea that if you imagine a ruler and you cut it in half or you add to it, you can ask a number of wonderful, motivationally interviewing type questions that solicit feedback and information from your patient. And again, I think it's time efficient because you don't have a lot of time. This may be an example of how you can do that.
Can I ask one more question?
Yeah.
Okay. So how long does it take to fill that out, and how often do you revisit it?
It's a 27-item screen, kind of a survey, so it's pretty quick. I couple that actually with an opiate risk tool. So I take a look at the risk assessment for aberrant behavior with opiates, and then oftentimes there's some interesting scales that kind of add to the story, if you will. But this is kind of like the patient's story. Oh yeah, this is what they're trying to tell the doctor. And again, hopefully we have the time, you have the time to hear the story in an efficient kind of a manner. So
I have 2 questions. Can you hear me?
Yeah, go ahead.
One is, what do you do if you have a high index of suspicion that the patient is a danger to themselves or society? How do you handle that? Number 2, when you suspect that the patient is really not compliant, how often do you contact the physician monitoring program, and how easy is it to get the information that you need if you do contact them, just to see if they're playing you?
I'll try to respond in a reverse order. And not being a physician, although you can have access to the physician monitoring program, I haven't done it with patients, but I believe it's fairly robust and responsive in order to log on and see what's going on. Regarding the dangerousness of an individual, unfortunately, chronic pain patients have a higher suicide rate than the general population. So that is absolutely an important issue to be cognizant of. I would strongly encourage you to have access to perhaps crisis line phone numbers for these individuals, and maybe an established relationship with your local hospital emergency room if they need to be transported or taken to a facility that could protect them. So that is a very real concern, and the prevalence rates are much higher amongst chronic persistent pain patients than other folks. So a very important issue.
What I'd add is that have a standard operating procedure, because it's going to come up, especially with opioids. I had a physician who was sharing that they had this patient for over a year where they were giving him 60 opioids. The person would come in, they'd pick up their prescription, they'd go every month. Just dream patient, come in, 5-minute kind of thing, get your refill, okay, check up, everything going good? Yeah, we're stable, we're good. Did a drug screen on the person and they didn't have any opioids in their system. So you're dealing with something that has street value, something that has high addictive potential, and standard operating procedure of a couple of things. One, are they not using it the way that you're prescribing it? Are they, you can't let them out of your office, or really, you have to hand them off so that they're safe if they're leaving and they don't have the capacity to drive a vehicle or leave. If you're the last professional who touches them, you can be in a world of liability. So having some kind of system, we have a detox center here that I work closely with, and so we already have a system set up so that if the individual, we'll take them over there, we give them an option. You can go over there, or they can have security escort you out, but we have to hand them off to somebody else for their care. The drug screens is a good blanket standard operating procedure if you choose to put that into your practice to find out exactly what's in the person's system. And it's not necessarily the opioid or you're trying to catch them, but if they're having high level THC or ethanol, alcohol in their system, that could have a major impact on the medication and how it's supposed to work and how it's supposed to be metabolized by the liver. We just had a person that I spent the weekend with in ICU a couple weeks ago because the person was given, he had a little bit of a surgery and they gave him Percocet. It was 10 325s, and he had an opioid naive person. Problem is the acetaminophen is what closed down the liver and was starting to close down the kidneys. The problem with that is the opioids are now creating a toxic, getting into a toxic level because the half-life is expanded over that 17 hours. So the person can't feel the problem. They're not going to they're not expelling. They have constipation. This was for 5 days. So they're living in a toxic kind of thing. They can't feel it, and they keep on pumping it in per the doctor's orders. So you have a double whammy kind of going there. By the time I got over there, the person was gray, sweaty, clammy, completely out of his mind, nodding out. And the emergency room physician said he was a couple pills away from overdosing. And this is just a guy who goes in to get a surgery or get his bone refixed and put some pins in it, right? So standard operating procedure, especially when you're dealing with this type of medication, and this medication is great. It's a tool. It works. It's for acute pain. But like Dr. Lewandowski's talking about, this is when we're looking at chronic pain and this is medication use is your maintenance plan, the only answer is more. The person's going to build their tolerance. And then you also have opioid-induced analgesia, where the opioids actually make the person more sensitive to pain. So we're creating our own kind of problems here when we don't have that exit strategy or define what success looks like. Long story longer. No, I'm kidding. procedure for the predictable is always good form.
Yeah, and I would reinforce what Paul's saying, that like your question about what do you do with somebody who's suicidal, I would just try to reinforce and remind us that if we can help them as a team. I think that medically focused individual sees this as an individual sport. And I think when they become chronic pain patients, it really has to transition to what I would call a team effort, so that there needs to be other members of the team, including emergency people for suicidal kinds of ideas. So let me continue here. We've got a couple minutes left. So change talk. What I hope to accomplish in this talk today is introduce the idea that even though you may not have a lot of time with this individual, if you can get them to provide some input, if you can get them to start looking at the role they play in treating themselves and taking care, use open-ended questions. And here's an example of categories of other ones. Questions that evoke change talk. You know, what worries you about this? One of my favorite questions in my intake when I do an interview for the first time is I ask people, I said, are you worried about not getting better? And many people, of course, say, well, so of course I'm worried about not getting better. But it is interesting, those people who say, no, I'm really not. And they're the ones that are usually, 2, 3, 7 years of pain. They realize this is where they're at. And by definition, I now know they're not in the beginning stages of change talk. They're now looking at what can I learn to do for myself. So the big question is, look at them from 35,000 feet. Where are they on this continuum of medical-based and focused treatment versus kind of this rehabilitation collaborative team effort? Other things here, and all of these are highlighted in this book, Motivational Interviewing in Healthcare, which is a great resource. So again, also the use of that ruler question, we talked about that earlier. The category of using extremes I found helpful. What's the worst thing that could happen if you don't make some of these changes? And solicit some feedback from that. Oh, that's great, Troy. So there you go. You can buy a couple right now.
Nice work, Troy.
Well, I'll be sending out the link for the book into the chat.
That's fabulous. So let me see here. So yeah, so again, categories of other questions. When you, after eliciting change questions, say, well, what are you going to do now? What do you think you're going to do? Tell me what the plan is from here. Get them to tell you what the next step is, and they will own more of it than if you tell them what the next step is necessarily. That's kind of the message of this talk today, I think. So some final thoughts. Motivation is part of the interaction, and you can facilitate that through the questions that you ask. It can be influenced. And if you're getting resistance, resistance may suggest that something's not working and that you need to do something different. And to argue for change or to demand change facilitates resistance. But with that, I also have kind of some resources here. It's also in the slides. So again, thank you very much. I hope this talk today has stimulated some thinking on your part and how you may interact a little differently with the very next person with persistent pain you see today or tomorrow. Any thoughts or comments?
Very good presentation. I appreciate it.
Thank you very much.
Thank you. Thank you.
Especially the team approach.
Absolutely. Yeah. It's a lot less heavy when you have more people helping you lift. Yeah.
Many hands make easy work.
Yes, many hands make easy work. Very good point. Well, again, thank you all for coming. In 2 weeks, we will meet again. And the topic in 2 weeks is going to be the 12 steps to proper prescribing. So we look forward to seeing you in 2 weeks for the next Pain Management Echo Talk.
All right. Thank you, everyone.